Thank you, everyone, for joining today's briefing session for the Family, Domestic and Sexual Violence and Child Sexual Abuse pilot, also referred to as FDSV pilot in this presentation. We'll just start by introducing the CHN team present here today. My name is Suman Shetty, and I'm the Program Manager for Family Safety here at CHN, and I manage the Family, Domestic Sexual Violence pilot. I'll get my teammate Laura to introduce herself.
Thanks, Suman. Hi, everyone. My name is Laura. I'm the Family Safety Project Officer here at Capital Health Network. And I'll pass over to Mamta.
Morning, everyone. My name is Mamta. I'm the Senior Manager here for the Health System Integration team. Thank you. And I'll pass it over to Sharon.
Yes, good morning, everybody. My name's Sharon Storr, and I'm the Procurement and Contract Management person here at CHN, just assisting someone through this tender process. Thank you.
Thanks, Sharon. Before we start, we'll say an acknowledgement of country. So we begin today by acknowledging the Ngunnawal people, the traditional custodians of the land on which we are meeting today, and pay our respects to their elders past and present. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We would also like to acknowledge and welcome any Aboriginal and Torres Strait Islander peoples attending today's event. So I'll start by providing a brief overview of how this briefing session will go. So first and foremost, the session will be recorded to ensure that the questions and answers can be captured accurately. It will be made available on our website for anyone who isn't here today. And it will also inform our Q&A document that will also be made available on the website. So any questions that you ask today will go into a Q&A document, which will be available on CHN tenders page. So we'll start with introducing what Capital Health Network does and provide a background to the supporting primary care response to family, domestic sexual violence and child sexual abuse pilot. And then we will run through the request for proposal and the service requirements and assessment criteria, and then provide an overview of the procurement and establishment timeline. And finally, we'll get to the questions stage, and you answer any questions that you may have. And please note that we may not be able to answer all questions today, and we might have to take some questions on notice and answer them in the Q&A document, which will be made available on CHN Tenders website next week. And as I'm speaking throughout the presentation, if any questions come to mind, please put them in the Q&A box on Zoom. Please do not put it in the chat function. That is for general discussion. So please put any questions in the Q&A box, and we will answer all the questions at the end of the presentation. But feel free to put them through as you think of them. So for those of you who may not be familiar with what CHN does, we are the primary health network for the ACT region. So PHNs were established by the Australian government with the key objectives of increasing the efficiency and effectiveness of health services for patients, particularly those at risk of poor health outcomes, and improving coordination of care to ensure patients receive the right care in the right place at the right time. And as you can see, we are working to meet these objectives across these 9 priority areas that are on the right side of the slide. And being the only primary health network in the ACT region, really, we do work quite closely with our local health system. We'll just go through some definitions before we proceed. For the purpose of this RFP, when we refer to primary healthcare, so primary healthcare is often the first contact that a person has with the health system, and it can be delivered in a range of settings by a range of providers. Primary healthcare essentially covers healthcare that is not related to an acute hospital visit and can include health promotion, prevention, early intervention, treatment and management of chronic conditions. And for the scope of this pilot, when we talk about primary healthcare professionals, we are referring to the whole of general practice, which is general practitioners, practice nurses, practice managers, allied health practitioners that are within the general practice, and also non-clinical staff within the practice. And also Aboriginal community-controlled primary healthcare service staffs, dentists, and the broader primary care allied health professionals. When we say victim survivors of FDSV, so we essentially mean people who have experienced family and domestic violence, sexual violence, child sexual abuse, or any form of gender-based violence. So this term is understood to acknowledge the strength and resilience shown by people who have experienced or are currently experiencing and living with violence. People who have experienced violence have different preferences about how they would like to be identified and may choose to use victim or survivor separately or another term altogether. And some people may prefer to use people who experience or are at the risk of experiencing violence. We endeavor to use inclusive language while acknowledging that language is also evolving and may not capture all experiences of victim survivorship in all the way that it exists. So to provide you with a background to the supporting primary care response to family domestic sexual violence and child sexual abuse pilot. So this grant funding was announced as part of the 2022-2023 March federal budget under the Supporting Health System Navigation for Victims and Survivors of Family Domestic and Sexual Violence measure. So the Australian government has allocated up to a total of $36.8 million for this funding opportunity. That's nationally across 3 financial years until 2025-2026. So this funding forms part of a package of initiatives to reduce all forms of family, domestic, and sexual violence against women and children, and to support the implementation of the National Plan to End Violence Against Women and Children. This initiative also directly responds to recommendations made by the National Strategy to Prevent and Respond to Child Sexual Abuse, the Royal Commission into Institutional Response to Child Sexual Abuse, and the House of Representatives Standing Committee on Social Policy and Legal Affairs Inquiry into Family Domestic Sexual Violence. So the research that supports this is that it's estimated that a full-time GP is likely to see up to 5 women per week who have experienced some form of intimate partner abuse in the last 12 months. And research also suggests that primary health professionals such as GPs are often the first point of health professional contact for victim survivors of family, domestic, and sexual violence. And as such, we see primary healthcare professionals playing a really important role in prevention, early identification, and responding to disclosures of family domestic sexual violence, and really maintaining engagement as part of an interdisciplinary team to support people that are experiencing violence. So therefore, this funding is to establish a pilot in the ACT to support primary healthcare professionals in the early identification and response to family, domestic, and sexual violence and child sexual abuse, coordination of referrals from primary care to FDSV support services in the community, and improving integration between primary healthcare and FDSV services sector, and also enhancing the service navigation for victim survivors of FDSV, and achieving this really through commissioning of FDSV link worker roles. So the pilot builds on national PHN model called the Recognized Respond Refer model, which is developed by Brisbane South PHN. And it has been trialed by 5 other PHN domestic family violence pilots that were funded under the 2019 to 2020 federal budget. And this included PHNs in New South Wales, Victoria, and the 1 PHN in Queensland, which was the Brisbane South PHN. So with this new round of funding, that is the 2022-2023 federal budget funding, so funds have been made available for each of those existing 6 PHNs to extend their domestic family violence pilot until 2025-2026 financial year, and also expanded to include sexual violence and child sexual abuse. And also for 1 PHN family domestic sexual violence and child sexual abuse pilot site to be established in each of the remaining states and territories across Australia. So the CHN family domestic sexual violence pilot, it's one of the new pilot regions. And nationally, a total of 11 PHNs are involved and in this pilot. So this is the recognized respond refer model that our pilot is based off. And the successful provider is expected to work in collaboration with CHN and key stakeholders from the sector to really localize and adapt this model. And as you can see, this model comprises of 6 influencing activities. Just provide a brief overview of what that means. So FDSV link workers, the first activity that is essentially establishing FDSV link workers to serve as a single point of referral for general practice or other primary care providers, and providing a level of care coordination for people affected by family domestic sexual violence, and followed by warm referrals to relevant support services. The second, workplace capacity building activity, that includes delivery of RICGP accredited FDSV training activities, development of organizational supports and resources, and informal training and advice provided by the FDSV link workers during their interactions and engagement with general practice and other primary care providers. The third activity is ensuring that we have a whole of practice approach, which means that all staff within the general practice or within a primary care practice have access to these FDSV link workers and the capacity building activities that they provide, which will create and foster a climate of disclosure within the practice and enable timely referrals to support services. The fourth is locality integration, which is to ensure a place-based approach is considered during the planning, establishment, and implementation of this model, and improving linkages between family domestic sexual violence responses at a primary care and FDSV sector level. And the fifth would be system influencing activities, which is to ensure that key stakeholders can really jointly work on overcoming system issues that may be encountered at a general practice or at a local health system level. And the last is evaluation, which is to inform and support the ongoing iteration and design of the model. So who will the funding support? So the primary care workforce and the FDSV link workers through CHN's FDSV pilot activities will aim to provide better care and service navigation for family and domestic violence victim survivors, sexual violence victim survivors, child sexual abuse victim survivors. And we acknowledge there are gender drivers of violence and complexities within understanding the experience of those impacted by family domestic sexual violence, including those who use violence. So this funding is designed to support victim survivors of family domestic sexual violence, which can include any person identified as a victim survivor. So this includes a victim survivor that may have used or uses violence. So the long-term outcomes of this pilot are really to improve primary healthcare sector capacity and capability to recognize, respond to, and refer people experiencing family domestic and sexual violence and child sexual abuse, and improve system integration between primary healthcare sector and specialist support services sector, and improve integration of primary healthcare services with territory level FDSV initiatives to really ensure a coordinated response, and also improve health system navigation for victim survivors, and improve health outcomes for people experiencing FDSV in the ACT region. The short and medium-term outcomes are really improving the understanding and awareness of the role of primary care sector in addressing FDSV, improving the readiness and confidence of primary care sector and primary healthcare professionals to address FDSV, improving recognition of FDSV by the primary care sector, and increasing referrals from primary care to family domestic sexual violence support services. And also improving the specialist support services, understanding of the role of primary healthcare and primary healthcare professionals in supporting victim survivors, and improving partnership and trust between those two sectors, and increasing, awareness as well, and increasing that continuous care coordination loop between primary care and FDSV support services. So that's that feedback loop back to GPs. So let's talk about what this RFP is about. So the request for proposal for family domestic sexual violence pilot. With this, CHN is seeking request for proposal from organizations interested in establishing FDSV link worker roles to really enhance primary healthcare knowledge and support the provision of better care and service navigation for victim survivors of FDSV that have been referred via primary healthcare. A total of $2.2 million is available for this pilot until June 30th of June 2026. Organizations have the option to propose for provision of services in either one, two, or all three specialized areas. So that's either family and domestic violence, sexual violence, and child sexual abuse separately, or a combination of those. Activities will be funded, as I mentioned, until 30th of June 2026. So who can apply for this RFP? Any organization in ACT with expertise in supporting people experiencing family and domestic violence and or sexual violence and or child sexual abuse is welcome to apply for this RFP. And we also would encourage any interested Aboriginal and Torres Strait Islander community organizations that are involved in providing FDSV support services within ACT to apply for this RFP. So I will not go into too much detail in this section. This is included in the RFP document that's available on CHN website. So the successful provider, it will be required to develop, establish, and deliver family domestic sexual violence pilot activities with the aim of strengthening primary care sector response to family domestic sexual violence, and integrating primary care and FDSV sector response to really provide better care for victim survivors of FDSV. So the activities required can be broadly categorized into these three components that you see on the left-hand side. So that is the workforce capacity building activities. That's the first one. And that's really to support primary care providers in better recognizing and responding to FDSV. So that will involve developing and delivering whole of practice training and resources for primary healthcare professionals in collaboration with CHN and key stakeholders. So we have a GP in our team who will also work on developing those resources with the successful provider. And engagement with general practices and other primary healthcare providers to really build relationship and rapport with staff and promote the FDSV training opportunities to primary care. The second component is the system integration measures. So as part of that, we will expect the successful provider to develop locally relevant care and referral pathways to support primary care to make appropriate referrals and support integration of primary care services with FDSV services sector, and establish a dedicated one point of referral service for primary healthcare staff to refer patients experiencing FDSV, provide ongoing engagement of primary care staff post-training to really assist in implementation of that training content and create a safe environment for disclosure within the practice. And also provide some initial case coordination, risk assessment, and safety planning, and warm referrals, followed by warm referrals to relevant support services for victim survivors that are referred from primary healthcare. The third component is the locality integration measure. And as part of this, we would expect the link workers to work closely with other FDSV link workers if there are other organizations that are commissioned as part of this pilot, and primary healthcare professionals to really ensure integration across activities that are delivered as part of this pilot, and to really integrate primary care into any ACT territory government initiatives and reforms. So the successful provider is required to establish a minimum of 3 dedicated family domestic sexual violence link workers to provide advice and support to primary care providers in recognizing and responding to patients impacted by domestic and family violence, sexual violence, and child sexual abuse. So in addition to providing advice and support, the link worker will receive direct patient referrals from the primary care sector. And upon receiving those referrals, depending on the capacity, the link worker will provide some initial case coordination and connect the patient to appropriate support services. All personnel that are employed to deliver or administer these services funded by CHN must have access to debriefing, clinical supervision, and or mentoring to ensure availability of support for clinical decisions and continuation of professional development. They must also maintain working with vulnerable people registration and be trained in trauma-informed care and cultural safety and cultural competency, and any specialist training in domestic family violence, sexual violence, and child sexual abuse. If the workforce does not currently have experience in delivering direct services to people experiencing any forms of those violence, then they will be expected to upskill through available courses. So it is a requirement of the service to be willing to work outside of normal business hours to support training for general practice and primary healthcare. So that's probably up to 8 p.m. And yeah, we would also expect the successful provider to participate in evaluation activities as directed by CHN, and this would involve contributing to the national evaluation of FDSV pilot that's being conducted by independent organization that's been commissioned by the Commonwealth to evaluate all the 11 PHNs that are part of this pilot, and that's Sachs Institute. So, and this will include the so the evaluation requirements are mentioned in the RFP document, so you can refer to those. So this, and if you have any questions, you can reach out to us. So what is out of scope within in this pilot and funding? So we acknowledge that in cases of gender-based violence, victim survivor may still be in contact or live with the perpetrators. And in these situations, family-based approaches may be required. And in some cases, people are both victim survivors and perpetrators of violence. For example, some adolescents using violence. We will be looking at developing some training for GPs around working safely with people who use violence. But that is as far as it goes in terms of what the funding can do with for people using violence. So funding is not designed to support users of violence that are also not victim survivors. And the funding cannot be used to deliver specialist FDSV services and crisis services. And the focus of the link worker role is really to develop and facilitate FDSV training, serve as a referral point, enhance and be available for capacity building in, with primary care, and enhance service navigation and integration. So the funding cannot be used for community education, although we recognize that is important equally. Fortunately, this funding cannot be used for community education. It's primarily for educating primary healthcare professionals. The other items that are out of scope include purchase of land and any major capital expenditure or major construction capital works, covering of retrospective costs or any costs incurred in the preparation of this RFP application or related documentations, subsidy of general ongoing administration of organizations, purchase or maintenance of equipment or motor vehicles, overseas travel, any activities for which other Commonwealth or territory government bodies have primary responsibility. This again is covered in the RFP documents. I will not go into much detail, but these are the main deliverables and reporting requirements that will be required of the successful provider. So a project plan, including a primary care training and capability building plan, a service model documentation and marketing and comms plan, stakeholder engagement plan, recruitment strategy. This will be due within a month of contract execution. Regular status meetings and reporting will be held, and like I mentioned before, the evaluation reporting that will be required by the independent evaluators at the Institute. And we will also collect performance and financial reporting. This will be at 6 monthly intervals. So CHN invites proposals from both solo providers who can demonstrate capacity and capability across all 3 specialized areas, and also multiple providers who may be looking to establish these link worker roles in either 1 or 2 of the specialized areas. So funding will be made available following the execution of a relevant services order with CHN through to 30th of June 2026. The amount of funding that is available is 2.2 million. And the funding available in that will be made available in 2024 financial year will be rolled over to 2024-2025 financial year. So there'll be 1.34 million that's available in that first year, and then $860,000 available in the 2025-2026 financial year. And we do anticipate service delivery under spends, and this will be explored with successful provider. And the funding is also further split in accordance with how the Commonwealth has split the funding across the 3 specialized areas. It's, so there's a total of $770,000 available for domestic and family violence pilot, and then around 642K available for sexual violence, and $787,000 available for child sexual abuse. Please also note that for the administration side of costs, there's a cutoff to the maximum is 14.5% of total budget that you can allocate towards admin costs. So this is just an overview of the assessment criteria. You would have already seen this in the RFP document. If you haven't, it is, as I mentioned previously, it's available on the CHN website. So it's also available on the response form, and it provides more details around what is required within these criteria. So when you do provide your response, please indicate which specialist area you will be proposing to establish link workers and provide services in. That is either it's domestic and family violence, sexual violence, or child sexual abuse, or all 3 or any 2. So the first criteria is the service delivery model, and this is a huge one. So the maximum word count of 2,000 words and holds a weighting of 35%. So in this, we are essentially asking you to provide some details around service delivery, how you'll deliver the services, and how you'll articulate your vision for the scope of the family domestic link workers role, and including an understanding of the local context and the unique needs of your target population group, and outline how you will deliver those services and support family domestic sexual violence victim survivors, and the general practice or primary care practice environment. As part of this, you will also outline how you will demonstrate program outcomes and experience measures. The second selection criteria is around experience, skills, and knowledge. Here we are requesting you to demonstrate experience in providing domestic and family violence and or sexual violence and or child sexual abuse support services. This holds a weighting of 25% and no more than 800 words. The third criteria is around workforce. So here we're requesting you to describe the proposed staffing profile, and that includes the number of link workers, and outlining your recruitment strategy and training and upskilling strategy. So this holds a weighting of 20% and with no more than 500 words plus 1-page profile that can include the staffing and training strategy. The The fourth criteria is governance structure and systems. Here we're requesting you to outline your proposal for the key governance structures and systems for establishing link worker roles. This holds a weighting of 10% and maximum 700 words. And the last criteria is budget and value for money. And here we're requesting you to include an itemized budget and an explanation of how the proposal will deliver value for money. And this has a weighting of 10% as well. And the word count is 500 plus 1 page proposed budget. There are additional requirements that please see the RFP for more details, but the additional requirements are you could provide these as an attachment. It's an overview of the current of your current organizational structure and any existing organizational level clinical or corporate governance frameworks. So this is a high-level procurement and establishment timeline. So the RFP is open now. It will close on the 22nd of March, 5 p.m. We aim to have the preferred provider identified by Wednesday, 17th April, and the contract finalized by mid-May 2024. And establishment taking place between May and July of 2024, and having the service commence in some form by the 1st of August 2024. So we are at the end of the briefing session. So please add any questions that you have into the Q&A box in Zoom, and we will be taking all the questions and answers, as I mentioned, from today and putting in the Q&A document, which will be made available on CHN Tenders website. So if you have any questions that you aren't able to ask today, please know that you also have the opportunity to send through any questions to our tenders inbox, which you can see on there. It's tenders@chnact.org.au by close of business Monday, 18th March. And we will provide a response to those in the Q&A document and share it with you. And we'll also be continually updating that Q&A document on CHN website as we get more questions between now and then. So we'll allow a few minutes for questions to come through.
Suman, we can start with the questions. We have 3 questions. So as you're answering them, attendance will add more.
Yes, I will just stop sharing my screen. Yeah. So, okay, I can see. So the first question that we have here is if these if the 3 link workers are for each area, that's DV, sexual violence and child sexual abuse combined, or for each area 3 are required. So it is 3 combined. So we are expecting 1 link worker for each of those components. So 1 link worker for domestic family violence, 1 for sexual violence, and 1 for child sexual abuse. So the next question that we've got here is, does this grant apply to informal link workers, that is upskilling allied health, to act as a link worker? Yes. So there is more details in the RFP around this, and we will include more information in the Q&A document. But yes, so you could have link workers. The link workers could be allied health workers that can be upskilled through specialist courses and training on family, domestic, sexual violence, child sexual abuse, and sexual violence, depending on which component they will be delivering services in. There is an opportunity to upskill your existing allied health workforce. Yes, so in terms of the next question that we have is, okay, so we have a question. Could you clarify what is meant by accredited FDSV training? Does it mean partnering with RCGP, QIP? Yes, so CHN, so we will help with that side of things. So we will work with the successful provider in the development of the training. And as I mentioned, we have a GP on our team. So they will take care of the accreditation side of things. So once we have the training developed, they will work with our ICGP to ensure that it's accredited. So GPs that are doing this training will get CPD points. So the successful provider does not need to worry about the accreditation side of things. Okay, so we do have a question here in terms of training. So is there any expectation whether training should be in person or if it could be delivered online? Also, if there's any indication of duration of training program, given that health professionals are always stretched with time. Yes, and I think absolutely agree with that. So what we've seen from evidence and from the past training is that there is more engagement with when it's in-person training. So what we would be expecting is some form of a combination of in-person and online training. There could be series of trainings, and the first training could be face-to-face, and there could be some training components for allied health that could be online. So it could be a combination, but we would expect some form of face-to-face training as well. And I think that question's gone. Oh yeah, and in terms of the duration of the training, we would expect the training to be no longer than ideally an hour or an hour and a half, no longer than that. So you could have different modules of training, and we could look at like foundational and then more in-depth training as well, but limiting it to no more than an hour and a half. So we have a question here around whether CHN has specific templates that you require applicants to use for budget or any other attachments for this tender, or can we use our own? Yes, so you can use your own. CHN does not provide budget templates, so you're free to use your own. Yes, there isn't an attachment or a template for any of the other criteria that's mentioned in the RFP, so you're free to use your own templates. Can funding be used for link workers' phone and IT requirements? Yes, yes. So that's the other question that we have, and yes, it can be used for that. Yes. So we have another question here that's around wanted to confirm. So yes, the tender submission is due on at 5 p.m. On 22nd of March. So that is when it is due. So we have a question here around, can a community service organization who hasn't offered DFSV services in the past apply to establish a new program? We do require the organization to have delivered some sort of support. So it doesn't need to be specialist support, but some form of engagement, because it would just be easier for that organization. We're expecting that organization to have those existing links with the other services in the sector. But you could always partner with an organization that does provide DFSV services and do a consortium application, and we would accept that, because if you're a community service organization that has specific focus on priority population groups, but do not provide DFSV services, then you can look at partnering with an organization that does provide DFSV services and apply as a consortium. So the next question that we have here is around, are there any limits to the location within ACT that FDSV link workers can be based from, acknowledging that traveling within ACT to meet with service providers and stakeholders will be required as part of the role? No limits to the location as long as it is within ACT, and we will be aiming to support general practices that are within ACT as well. So that's 103 general practices within ACT, but not necessarily all. We will go through an EOI process with the practices to see which of the practices are interested, and that's how you will engage with them. There is a question here around if two organizations collaborate together on this tender, can both utilize 14.5% towards admin or management costs? I think I might get someone else from our CHN panel to answer this question if they're able to. Sharon, are you able to answer this question?
Yeah, this is obviously going to come down to contract negotiation when we have preferred provider, I guess. Potentially we could have a preferred provider that does do a subcontract arrangement. So the budget and contract would go to the one provider with that 14.5%, and then it's up to that preferred provider to subcontract out. So how they organise that's at their end. However, I would seek clarification from the finance team to put something better in writing into our Q&A for this one. Unless Rachel has comment on that. You're on mute.
Sorry, I sort of came partway through. What was the question? I listened to what you said, Sharon, but I wasn't quite sure where.
Yeah, it's in relation to two organisations collaborating together on the tender. Mm-hmm. And can they both utilise that 14.5% towards admin and management costs?
I guess it depends how it's awarded. If they're, yeah, I would agree. It's how it's awarded. If they are a subcontractor of a main person, I would say no, because the main person holds the contract. If, however, as with our other contracts, it's split and there's two providers who each get a contract from us to deliver, then yes, they would be able to.
Yep.
If that makes sense. I think that echoes what you were saying. Yeah.
Yeah. Yep, thank you. Thanks, Sharon. Thanks, Rachel. So we have another question here, which is if an archer applies is the expectation that they will focus their link worker roles on building capacity in relation to working with and supporting Aboriginal community, or would it have to be ACT community-wide? So if an ACHO applies for having link workers, they will absolutely work with supporting the Aboriginal community and will be expected to accept referrals that come through from people that identify as Aboriginal Torres Strait Islander. So it wouldn't necessarily be community-wide, but we would expect you to be involved in some form of capacity building in terms of the training development that will be for primary care and GPs across ACT, which will be again specific to working and supporting patients that identify as Aboriginal Torres Strait Islanders. So it wouldn't be for all of the ACT community. Hopefully that answers your question. Can you, so there's a question around, can you explain working after hours, weekend or late evening, I suppose? Yes. So, so when we say working after hours, it wouldn't be on a daily basis. It would essentially be when the trainings are scheduled with primary care, and primary care usually prefers training in the after hours. So that would not be on a weekend. It would essentially be Monday to Friday, would be up until 8 p.m. Trainings usually between 6 to 8 p.m. is that's how it would work. So, and again, as I mentioned, it wouldn't be an everyday thing. It would be when the trainings are scheduled. So there's a question around if services can only be delivered to clinical and non-clinical staff within ACT GP practices, or is it possible for training to be delivered to ACT allied health clinicians not working with general practices? So first off, we will be looking at training in the first phase for general practices, the whole of general practice, and that includes allied health within the general practice and the clinical, non-clinical staff within general practice. But we will also be looking at developing training with the successful provider for and delivering those trainings for allied health that's outside of the general practice. So, physios, osteopaths, and any other allied health professionals that may benefit from that training, and possibly also from that, from the link worker in terms of being able to send referrals through to them, because we have heard from our consultations that they do see a lot of people that disclose violence to them. So I think that's all the questions that we have here right now. Kunal, is there anything in the chat?
There's none.
None, okay. So we'll probably give a few more minutes to anyone that has any other questions. And also, as I've mentioned previously, if you have any questions and anything that comes up while you're working on the application, please just send those questions through to our tenders inbox. So it's tenders@chnact.org.au, but before close of business, 18th March. Yes, and yes. Thanks, Laura, for putting that on the chat. Sorry, there's another question. It's asking if an ACHO was successful, would they have to accept referrals to work with non-Aboriginal community? No. So you will only be supporting, if an ACHO was successful in this, you'll only be working with Aboriginal communities. So you wouldn't be supporting non-Aboriginal community. It would only be people that identify as Aboriginal Torres Strait Islanders that are experiencing family domestic sexual violence. Sorry if that wasn't clear earlier.
If there's no further questions, we can end the session.
Yeah.
Yeah.
Thank you everyone for joining us today, and we look forward to seeing your applications.